And I'm going to introduce our panelists who are going to talk in detail about some of these various practices. First up, I'm going to introduce Dr. Ursula Whiteside. She's a psychologist and suicide treatment researcher. Her work focuses on dialectical behavior therapy, DBT, which was developed by Marsha Linehan. Ursula is the founder of the nonprofit NowMattersNow.org, a free online public resource with the mission to reduce suffering and suicide through science. It's an incredible website. I know she's going to talk about it, but I highly recommend it. It features video-based stories of coping and resilience through strategies from DBT.
I want to take a moment before we begin to acknowledge the native lands that we're on. And that will also be relevant for the moments that I have with you today. In my 20 years working in healthcare with suicidal patients, two major themes seem to arise over and over and over again. And those are that as providers, as clinicians, we often feel very stuck to support our suicidal patients. We don't feel like we have the resources and the referral sources to do the best care. But in talking to people who've been suicidal and who have survived and thrived, they say that very small things, very simple things can make an enormous difference in their recovery. And I'm here to talk to you about those today. What I'm talking about is on the Now Matters Now website, which was actually developed at Kaiser, Washington. So the tools and practices that you'll see here today were developed as part of research funding that happened at the university, at Kaiser Permanente Research Institute. One of the things that's very helpful for providers to know is that the language that they use regarding suicidal patients really matters. And suicidal patients can smell it. They can smell the judgment, and it matters. And simple language changes can make a big difference, including changing our language from committed suicide to died by suicide. Another thing that can be very useful for providers is to have a way to talk about suicide, to have a way to explain it to their patients and to explain it to other providers. And what we have here is Marsha Linehan's biopsychosocial theory of emotion dysregulation, and I've just called it the stress model for short. And what you have here are two different individuals. The person in green is the person whose emotional baseline or stress level is lower than the person in tan. And what happens that for some of us, our emotional baseline, our emotional stress level runs hotter than other people. And that is due to our biology, that's due to social determinants, that's due to environmental stressors such as discrimination. And what happens is when a stressful event occurs, our emotions rise more quickly, they stay there for longer, and they take longer to come down. And for people who have this experience, this emotionality, it can be a very beautiful thing, but also it can be a painful thing, especially because people in the green zone really don't understand somebody who is in the tan zone. They don't really understand someone who's at that peak. So we call somebody who's experiencing that really intense emotionality in response to a trigger, we call someone like that, they're experiencing emotional fire. They're on fire emotionally. And we really know what to do when someone's on fire physically, right? When you're on fire physically, we've learned since elementary school to stop, drop, and roll. It's in the back of our brain. We've had it there so long. But we've never learned what to do when we're on fire emotionally. And we were, Dr. Mordecai was talking earlier about impulsive suicide attempts. And sometimes what happens is people think, well, they throw up their hands, well, maybe there's nothing we can do in that situation because it was unplanned. We're using the term unplanned more and more. And this is reflected in the research that my colleague Julie Richards and I did at Kaiser Permanente Washington Health Research Institute that were reflected here in this statement. And this is a person who recently attempted suicide said, and many of our interviewees said this, I didn't wake up in the morning and think that I was going to kill myself. The good news is that that intense experience of emotionality that overcame this person following a very stressful trigger and led to their suicide attempt, the good news is that there are things you can do and to manage a situation. And one of those strategies is called ice water or cold water. It's a dialectical behavior therapy strategy from this treatment that Julie mentioned in the beginning that is shown to reduce suicide attempts. So I'm going to show you an example of ice water. So these are simple things that healthcare providers can orient patients to. This is me putting my head in a bucket to demonstrate in a video how you would use the strategy to help reduce intense emotional arousal, to bring that emotions down when the person is emotionally on fire. It is also a bit painful, so that's me demonstrating and trying to bring a little humor here. It hurts a little bit. But what about for the clinician in the room? The person who is sitting with the patient, the primary care provider who's sitting with the patient who came in because they've got diabetic nerve pain. But then in the process of screening for depression, it turns out that this person is having suicidal thoughts, and not only are they having suicidal thoughts, but they have a plan to harm themselves in the next few weeks. What do you do in this situation? Well, in my work with people who've had suicidal experiences, and from my own personal experiences having had suicidal thoughts, these are what they say is most helpful. That if you are sitting with somebody who's suicidal, the first and most important thing is that you do not panic. And sometimes it helps to remember that the vast majority of people who have suicidal thoughts, even severe suicidal thoughts, do not go on to kill themselves. So you can slow down and be present with that person. And not only being present, but make sure you're providing hope. And I'll talk about another way to do that in a moment. So what to do? Recommended standard care for suicidal patients includes something called safety planning. These first two steps are safety planning. Having somebody in the session or in that encounter put the Suicide Prevention Lifeline in their phone, reducing the distance between them and help. And addressing guns is always important. That can take a lot of time or a little time, but if it takes a lot of time, it's definitely worth it with a suicidal client. And give someone a caring message. You've been hearing about caring contacts. This is an example of a caring contact. So I'm the provider. This is the patient I just described. And we've had a discussion about getting the guns out of the home and having them stored elsewhere for now. We've had him put the Suicide Prevention Lifeline in his phone. And then what I say at the end is, I said, I know, we've only met for a few minutes, but could you hold on for a second? I'd like you to give you something to hold on to. I know right now that not a lot of people in your life are happy with you, but I want you to know I'm looking forward to seeing you again. And then just take a few minutes to write this note. That whole discussion took less than a minute. What we know is that caring contacts can prevent suicide. And providing hope can mean things like, I'm looking forward to seeing you again. I see that you have gone through hard things before, and so I have a lot of hope for you. Those are the types of things, or I like you. It's communicating that in some way. This is a card that you can get on the Now Matters Now website, or you can write it on an after visit summary for primary care or otherwise. This is a nowmattersnow.org website that I've mentioned before. It has a ton of resources, and it's structured around dialectical behavior therapy skills, which are those tools like the ice water to manage emotional distress and cope ahead. We're going to watch an example video from that website.
So the skill of opposite action is where you, exactly what it says, do opposite of what you feel like doing. I was depressed, and when you're depressed, I found that with me, I wanted to stay in, I wanted to stay isolated, not do a lot of activities. And so with opposite action, you do exactly the opposite of what you feel like doing. I had to go to group, and it was cold outside, and I was nice in my warm bed. I would think to myself, instead of just trying to see the whole morning, take it in, which would be overwhelming, I would just tell myself I'm going to just sit up and stretch and see how good that feels. And so I would do that. And then the next step would be I'm just going to go take a warm shower and enjoy that. And then I would go further. I'm going to just get dressed in my favorite outfit and get all fixed up, do my hair, do my makeup. And that would help me to start going. When I'd step outside the house, I'd remember I have to go catch the bus up a hill, a really steep hill. So for that, I would just say to myself, I'm just going to take one step. And then I tell myself, I'm just going to take one more step and one more step. And before I knew it, I was up the hill. And of course, then I would reward myself with coffee because I love coffee. So I found that opposite action is one of the skills that to me is really what made the difference between how I was feeling and what I was doing.
I love Diana. This resource, a paper is coming out actually at 10:45 a.m. today that shows that this website is associated with reductions in suicidal thoughts. So visits of only minutes, people reported reduced suicidal thoughts, reduced negative emotions, and also this was true for middle-aged men. So we're excited about that. That's the Journal of Medical Internet Research. The idea with this website is that people would have the tools to plug into these different pieces of the stress model. These are all skills or tools that are available on that website. I want to leave you with this, which is that evidence-based treatment for suicidal people is really expensive. And so I think we need to be thinking as this work moves forward with suicide prevention that what we create needs to be readily accessible, and that people who are in situations that are unjust can benefit from additional strategies to manage that experience. And that doesn't mean that that's okay that that situation is happening.
Ursula, I'll start with you. How should someone who attended today's event get started on trying to implement or change their healthcare system using these best practices?
I think what we see when we're going in to train new health systems is that things go much better when you've had those conversations and inspired leadership from the beginning. As many of you know, if they're not on board, then it's much harder to get things happen. But not only leadership, but the frontline champions make such a big difference. And so putting the time in up front before going to do a training, I think can make things go much better.
I'd agree. I am a zero suicide champion, and I started off for my region. And I think the key for Northwest Permanente was that we have a program manager that's assigned to suicide prevention, which wasn't the case for all of the regions. So it really helped to keep us organized and do all of that pre-work, because there's a lot of work that goes into a training, into getting leadership buy-in, all the the 7 pieces of the zero suicide model.
So really kind of working with leadership, but also having sort of a dedicated staff person, even if it's not their full time, but who's driving the initiative so that they are the hub and everything goes through them.
Exactly.
So if you knew then what you know now at Kaiser, what would you do differently? As you guys have been involved in wonderful suicide prevention work and the adoption of zero suicide, what might you have done differently if you knew something then?
So I've thought a lot about that, because we all have regrets, but I think making sure that we keep the principle of making it super easy to do the right thing, always at front and center. Trying to get staff to do something different, whether it's a mental health clinician or primary care doctor. If we don't make it easy for them, we actually put them at risk, because they know what the right thing is to do. Like they should be asking these questions, or they should be referring these patients, but we make them feel guilty if we didn't make it easier for them to do. So I think that's one thing that I would change, is make sure that the electronic medical record is like super clean and easy to use, that we make the whole process like foolproof. The other thing is really explaining the name zero suicide before you introduce it into a system. We kind of later on found it's better to explain it as if we're saying zero defects in our care for suicidal patients, because our clinicians feel very guilty when they lose a patient. They feel like the organization was shooting for zero, and I struck out, and now I'm bringing the whole batting average down for the entire team. So we really don't want our clinicians to feel blamed at all.
So how have you, in that vein, how have you managed, because suicide deaths have occurred despite these practices being embedded, how has your system kind of bounced back after a suicide has occurred?
Well, that's an ongoing process for all of our regions. I can speak to what we've done in our region, and what we're trying to do for the other regions is having a really strong care for the caregiver program. I think our Southern California region is probably the strongest with that, where not just from suicide, but from an overdose or an unexpected death. Like when we support our clinicians after a trauma that that really helps. And really, it's debriefing it in a way that's not traumatizing, and really putting the onus on the system. It's always the system's responsibility. If a clinician didn't have time to do a risk assessment, the system should have been able to make that clinician have time. If the clinician didn't know how to do a safety plan intervention, the system needs to make sure that we're training all of our staff. So really trying to take it off of the individual and put it on the larger organization.
What, Ursula, maybe are some common obstacles you've seen as healthcare systems have looked to adopt these practices, and how have they overcome some of these obstacles?
I think starting with policies and procedure changes, that it can be difficult to do this on your own. I think that's what's really helpful about attending like a Zero Suicide Academy or using the zerosuicide.com website, is it has all these examples of how people have done these things already. I think that's one thing. Yeah.
And just in case I didn't mention it, I'm not sure I spoke about the website, is zerosuicide.com, but there's also a really robust listserv that's free and people can sign up for. And I think it's one of the most gracious communities I've ever been a part of. I think people don't want to reinvent the wheel, and so people throw their questions up. Do you have policies for youth, or how have you trained your crisis line staff? And people very, very willingly share. So another resource might be to sign up for the listserv.
I think too, it can be really intimidating to, try and train all your staff on evidence-based interventions for suicide prevention. So I think that giving systems permission to say part of training, which is an element of zero suicide, part of training is training staff up to par on all of these new things that you're implementing, and that you get credit for doing the train element of zero suicide, for doing that work, making the system responsible for that change.
And I think, Pavan, you mentioned that despite rolling out maybe a safety plan tool or Columbia, people might have said if they weren't trained in using it at first, they were just sort of being told what to do but not how to do it.
Right, and that it's effective, that it does work. So people really have to believe that it's going to work.
Do you have any other additional ideas about sort of commonly faced obstacles that you've experienced and how you all overcame them?
So, with a large group of physicians and a large group of staff, sometimes we'll get, pushback and say, like, we don't need to change what we're doing. You need to hire 1,000 more therapists, and then we can get our suicides closer to zero. It would be nice if there were that many clinicians out there. We're always hiring, but really trying to make sure that each clinical touch has safe practices to be able to screen, assess, and treat our suicidal patients. So one of the things that we did to kind of judo move that is we asked our staff, our labor, to participate with us in developing our policy and procedure. So we said, this is what we want our standard of care to be, but we want you to help us figure out what that looks like. So we went to our emergency room, mental health clinicians. We went to our rapid access clinicians. We went to our telephone triage folks, and we gave them these large, pieces of paper and had them map out the workflow, and they gave us ideas of how they could clean it up. And so that kind of working together was really successful, I think, for at least in the Northwest region.
Michelle, you talked a lot about the research and certainly the use of some of these specific intervention in military and veterans. What does the research say, if you know, about doing some of these practices with youth or with tribes or with other populations?
Yeah, it's where's my mic? Yeah, it's been less extensively explored, particularly with tribes. There has been some work in young adult and youth populations, but the majority of work has been looking at adults.
So where might you invest your healthcare dollar? I mean, maybe you can't say this because you're SAMHSA, so.
I can't. That's the one thing I can't say.
So perhaps if either of you have any thoughts about where research could go that would really help to improve healthcare.
Well, I'm really excited about creating storytellers. So every time somebody has gone through a mental health or addiction issue, there's a potential for a beautiful story, and then there's a potential for a lot of people to have exposure to that story and maybe find it useful. So I think that I'd like to create an army of storytellers and then evaluate whether that's effective. And I think the tool that I shared today is one potential place that something like that could be done. But I think there are new innovative things that we can do, but we just can't take forever to do them. And I think that's one of our limitations.
I like storytelling, and I think that's why I got into this field and what keeps me going. So that's I totally I'm curious about how that would go. If I had a Christmas list, what would be on my list? I think probably really investment in our infrastructure, in the electronic medical records, and in how our just to really make it super easy for our staff to be able to ask questions about suicide, to do the safety plan. So I talked about the vital behaviors, and we're already starting to introduce tablets into our clinics in Georgia, Northern California, and Southern California, and I can't wait for my region to get it, because I would love to be able to know when someone is suicidal before I even go out to the waiting room and get them. And I mean, just in general, I'd love that to be there for primary care as well. And I just want to make it, just reiterate that like 10 times. We want to make it really easy to do the right thing. Just like somebody in the OR, we're not going to leave forceps in someone's body. We're going to do a count. We're going to make there's a process for that. We can totally prevent that from ever happening. And so instead of thinking of suicide as a never event, want to make sure it's whenever somebody presents with these symptoms, these are always going to happen. We're always going to assess risk, and we're just going to make it as super easy as possible.
So are there any questions from the audience? And I think there's a microphone being passed around.
Hi, good morning. Can you hear me? Okay, great. So hi, thank you so much for the panel. One of the things that I'm curious about within the care systems is how are we empowering and utilizing family members as mandated reporters, for instance, or first lines of protection and defense for other family members who are returning with trauma symptoms that then could be predictive indicators for suicide. So how are your health systems working with parents of maybe wounded soldiers or wives of veterans coming back that deal with a lot of the vicarious trauma issues from those incidents, and having them be filters into your system to create a larger spectrum of care?
Michelle, do you want to answer, or what?
I can.
Start?
Yeah, I can start with that one. So I didn't put that as a vital behavior yet, because it's not. We don't have it as observable, but we really want to make sure that when we've identified someone that's at risk for suicide, that we have a conversation about who's important to them, whether it's a loved one or a family, and have them sign a release of information before they leave the office. So I would love to have that as something that we can record as data that is an always happen event after someone presents with high risk of suicide. The other piece is the Stanley and Brown Safety Plan Intervention has a piece about talking to family, and I think something that we've learned is that you can have the safety plan with the patient, and we talk about who are you going to rely on, when your symptoms get to this level. But we also have to make sure that they talk to that person, and that we invite that person to come in for the next session. So that's a little bit of a pitfall. We found that we introduced the safety plan intervention, and then we found some of our parents of members were saying, hey, like, I'm on that list, but nobody told me I'm on that list. So, when we release someone from the emergency room, or from, we see someone in the clinic, we have to make sure that we call them. And I think Centerstone is another agency that I really look at as an inspiration. And they have an always event model where they make sure that they confirm that lethal means are removed before the end of the day. So if they see someone at 1 o'clock in the clinic and they're suicidal, they don't just tell the patient, hey, we need to secure access to your firearms. They also reach out and confirm that before the end of the day.
And I can also just add, piggybacking on Pavan's comment, that I think the safety plan is a really useful tool, as he was saying. And what I have typically done in my practice is that with someone at risk for suicide, I use that as an opportunity when they're providing the contacts for people they would feel comfortable reaching out to. I use that as an opportunity often to get consent from them to contact that family member in a time or friend in a time of distress. And so for me, that's been helpful because I think a lot of clinicians struggle when there is an acute crisis and they're thinking about potentially violating confidentiality. It can eliminate that problem if you've gotten informed consent ahead of time.
Yeah, I think it's one of the keys is education. When you're doing suicide care, you really have to educate the people providing the treatment, educate the system, educate the patient, and educate their family and loved ones, and not shy away because of HIPAA, not make assumptions that your providers know, and not be afraid to really sit down and collaboratively look with your patient about what is this thing that we're treating you for. We educate people in the medical world. If you have a new diagnosis, a heart disease, challenge, we do a lot of education about that. We have to do the same thing in mental health and specifically with suicide care. So I want to thank all of our panelists for today's conversation, and thank you for allowing us to be here. My job is to tell you that you have a 10-minute break now, too. So thank you very much.